This week I will be discussing gonorrhea and chlamydia infections in pregnancy. In 2021, the CDC reported a prevalence of 0.3%, an incidence of 310 per 100,000 pregnancies that were affected by gonorrhea, and for chlamydia, 7.4% prevalence and 1,843 per 100,000 pregnancies of incidences were affected. These both are sexually transmitted infections, and this can be passed from mother to baby as the baby passes through the birth canal. And some increased risks for mom contracting these infections are multiple sex partners, a new sex partner, a partner that with a known HIV or STI. And the CDC recommends that all pregnant women are screened for gonorrhea and chlamydia at their first visit, and then again if having any symptoms or risk factors are present. Now, some risks for a mom, prenatal, and fetal, if they do have these infections, are pelvic inflammatory disease for mom, ectopic pregnancy, and infertility. Prenatal is premature birth, premature rupture of the membranes, miscarriage, stillbirth, and a low birth weight. And for fetal concerns is that gonorrhea can cause conjunctivitis, which typically occurs 2 to 3 days after birth through passage of the birth canal, sepsis, low birth weight, and melt sores, and chlamydia can cause pneumonia, conjunctivitis, and low birth weight. Now, a typical patient presentation, some suggestive concerns would be burning with urination or discomfort, vaginal discharge, bleeding, abdominal pain or discomfort, pain with intercourse. If there is sexual activity that would include anal or oral, they could complain about rectal pain and bleeding or sore throat. And objective things on exam to look out for, you will probably notice some discharge in the endocervical canal. The cervix will be more friable, vaginal bleeding. For throat concerns, pain, redness, and white spots or sores, and rectal concerns, pain, bleeding, and mucus discharge. Typically, symptoms will appear within 2 weeks of infection, but it can take 30 days. So it can appear within 2 weeks of the patient coming in contact with somebody who is infected with gonorrhea or chlamydia. Differential diagnoses include bacterial vaginosis, candidiasis, trichomonas, myoplasma infection, and syphilis. And then for diagnostic, it's typically collected either with a vaginal or cervical swab or first void urine, and the swab is a nucleic acid amplification test. And here I just inserted a picture of what typically you would see in practice use. So there is a different urine collection versus cervical versus vaginal collection. And then for treatment and follow-up, the main thing that you want to focus on outside of just making sure that mom is treated is prevent transmission to infant during passage through the birth canal. So if infection is noted while the patient's in labor, or they're currently being treated and they go into labor, considering a C-section to avoid transmission is something to think about. And for active infections, you would want to treat chlamydia with azithromycin 1 gram orally in a single dose. Alternatively, you can do amoxicillin 500 milligrams 3 times a day for 7 days. And you would want to test for a cure, meaning that you would want to retest the patient to ensure that the treatment has completely cleared the infection. And you want to wait at least 4 weeks before doing this. For gonorrhea treatment, this is a ceftriaxone 500 milligram IM injection for patients that weigh less than 150 kilograms, and 1 gram IM for a patient that weighs more than 150 kilograms. So main thing to take away with this is that it is an IM injection, so you will likely need to give this in office. And then you would also want to test for a cure, waiting at least 4 weeks, but within 3 months. And if there's concerns for pelvic inflammatory disease, then you would want to hospitalize the patient and give her IV antibiotics. important teaching. You want to make sure that the partner is treated as well. So certainly if a patient is positive and they have a partner and they know that their partner is not being treated, you can send in antibiotics for their partner or have their partner follow up with their primary care doctor. You would want to avoid sexual activity for 7 days and only resume sex if symptoms have resolved and your partner is treated. Screening for HIV and other STIs if these infections are present. There are no additional recommendations for fetal well-being screening with these infections alone. So you would want to just make sure that mom is keeping up to date with her regular prenatal visits. You could consider close follow-ups if it is something that you're concerned that mom might not, just be able to do. If it's, say it's early in pregnancy and you're not expecting to have her come back for 4 weeks and you really want to make sure you follow up on this, you could always schedule an earlier follow-up, but there's no additional fetal well-being testing that needs to be done with these alone. And then also just discussing safe sex practices. I think a big take home is a lot of times when a woman is pregnant, say they have a new partner, they think, oh, I don't need to use a condom because I can't get pregnant. And they don't really keep in the forefront of their mind that this can prevent STI transmission as well. And here's my references. Thanks so much.